Welcome to the second episode of the Progress Profile, Alzheimer's Research in Focus, a series that delves into the research, diagnosis, and treatment of Alzheimer's disease. My name is Lindsay Simas. I'm a licensed psychologist and the Director of Business Development for Pearson Clinical Assessment's Pharmaceutical Division. In this next episode of our series, we'll discuss the amyloid hypothesis, a topic that has dominated Alzheimer's research for decades. For those who aren't familiar, amyloid refers to the sticky protein clumps called amyloid plaques that build up in the brain and cause Alzheimer's disease by disrupting communication between the brain cells. The plaques are made up primarily of a protein called beta amyloid. When too much beta amyloid builds up in the brain, it can lead to cell damage, memory loss, and other hallmark symptoms of Alzheimer's disease. To guide us through a deeper exploration of amyloid is our moderator, the fabulous Dr. John Harrison. He is joined by the highly esteemed Dr. Philip Scheltens. Dr. Scheltens is a leading expert in cognitive neurology and Alzheimer's disease, with a focus on neuroimaging and biomarkers. He's widely published and internationally recognized for his groundbreaking work in dementia diagnosis, particularly his pioneering research on using MRI to identify hippocampal atrophy in Alzheimer's disease. Dr. Scheltens was elected to the Royal Dutch Academy of Arts and Sciences and was awarded the European Grand Prix for Alzheimer's disease. And now I'm going to hand it over to you, Dr. Harrison.
Lindsay, lovely to see you as always, and thank you for that wonderful introduction. Philip, lovely to see you too. Great to have you here. Shall we begin our discussion?
Let's do that. Hi, John. Good to be here
Excellent.
with you.
Let's begin with this. So we're in an era where we have a handle on the pathology that leads to Alzheimer's disease. So maybe let's start with a discussion of amyloid and tau. Can you explain for our audience the role of these proteins in Alzheimer's disease and other forms of dementia?
Yeah, good question, John. And as it was introduced as well, it's all about the amyloid hypothesis that was formulated many, many years ago. Many of the listeners were probably not even born then. And it's about sort of thinking that amyloid deposits are actually the primary, I would say, focus and the primary start of the disease at the earliest phase. By having these clunks of amyloid protein in between the cells, so it's an extracellular deposit, disrupting discussions between cells, so network disruption, and also leading to a cascade that involves tau deposition. Tau is another very important protein involved in Alzheimer's disease, and the two of them then lead to neurodegeneration, which is sort of the end of the cascade. And all of the three different parts, so amyloid deposition, tau formulation, which is intracellular, so that's the difference between amyloid, intracellular, then goes out of the cell, forms clumps, and is actually sort of hurting the brain and hurting the communication between cells, leading to loss of neurons, which is neurodegeneration. And all of these three individually lead to cognitive decline. And that is what we then sort of call dementia in the end. But very early on already, each of these, and especially amyloid, has been shown to already cause cognitive decline in its earliest form.
That's a great place to start, Philip. And it's that idea that this process begins a very long time before we have any clinical signs of presentation. So that idea sort of sets the scene nicely about the importance of disease detection. So we're starting to get to blood biomarkers being approved for use. In that context, do you think there's still a role for neuroimaging techniques in the early detection of Alzheimer's disease?
Those are many questions at the same time, John. I think to pick up on your point, yes, it has been proven using biomarkers like amyloid PET, for instance, that these changes, this amyloid deposition and misfolding of amyloid protein actually is a better terminology, and then leading up to these clunks that actually harm the rest of the brain. Neuroinflammation is, by the way, also involved. That happens maybe 10, 15, some people say 20 years before the first cognitive complaints occur. So yes, there is a long sort of preclinical phase of Alzheimer's disease that would lend itself actually to early detection if we would apply sort of imaging techniques like amyloid PET, or as you say now, blood-based biomarkers targeting the presence of amyloid and the presence of tau in the earliest phase, perhaps even before patients are complaining about memory or have actually established memory dysfunction. That's something for the future, I would say. That's not the case now, because then you would go out into the community and do these tests randomly, and that's not what we advise, because there is no cure at this moment. There is no remedy for this particular amyloid deposition at a very early stage to take care of. So I wouldn't advocate that, but it's something to think about in the not so distant future, I think, based on the fact that this pathology, amyloid first and foremost, but also tau pathology, occurs before the first symptoms are noticed by patients themselves, but also by the caregivers, or they're not caregivers yet, but people around the patient.
Yeah, and as a dyed-in-the-wool cognitivist, Philip, I'm always concerned there's still a role for my brother and sister psychologists in this.
Yeah.
And you mentioned that idea that these technologies are expensive, invasive, and not readily available. Is the role for cognitive testing maybe to do a first pass to see if people have any change, and maybe then refer them on to these other procedures?
For now, as the state is, yes, that's absolutely true. Because many of us at a certain age have complaints anyhow, and everybody forgets names and has issues with sort of not remembering certain events, etc. That can be quite normal, actually. So first and foremost, I think cognitive testing is there to establish that there is actually a deficit. And that can be a memory deficit, or a executive dysfunction, function deficit, or a language deficit, or any other domain that is implied in ultimately what we call dementia. So yes, that's extremely important. Whether this is something to do first, I mean, there's a lot of discussion there whether these tests are sensitive enough to pick up the earliest changes that would lead then to a biomarker assessment. I think yes, but again, here also I would say this is not something to do in a general sort of um, population approach. It is standard as people come to a memory clinic because they have certain complaints, or their family members have complaints about the patient, that the first thing you do is really establish, is there a deficit? Is there something that is actually objective and can be sort of shown on test? And that would then lead to further examinations of what's the cause of that deficit. And then you can talk about imaging, biomarkers, and anything else that you can do.
That's really helpful, Philip. And in the context of Alzheimer's disease, I think our general experience, probably implied by the expression memory clinic, is we typically expect people to come to us because they have some kind of memory problem. But in the last few years, I think you and I have witnessed now quite a few clinical presentations, even very early on, where there may be some challenge attached to memory, but there's often some other cognitive deficit, and maybe even across a number of domains. And I think of that particularly in the context of the wider idea of dementia. So in Alzheimer's disease, we tend to look for episodic memory issues, but we've got it in the practice, I think, and I think this is something you do very well in Amsterdam, is to look for evidence of deficits of executive dysfunction, working memory, concentration,
Mm-hmm.
praxis, language. And presumably in these other dementias, it might be other cognitive domains that are more important than episodic
Yes.
memory.
Yeah. No, absolutely true. So, I mean, you said it all, and I think that's absolutely true. In Alzheimer's disease, typically there is episodic memory impairment as the first sort of, I would say, not only complaint but also objective, I would say, deficit that you can establish using the well-known tests. But in the word typical, it already implies that there are also atypical cases of Alzheimer's disease where there is no memory impairment at all. There may be a language deficit, there may be an executive dysfunction first, or there may be practic issues, or there may be disorientation. There may be several other cognitive domains that are sort of already affected way before memory. And then we call these atypical cases. And we know this now, and we didn't know this before, because we know this now because when we examine these atypical cases with the regular biomarkers, we find Alzheimer pathology. So we now can say, well, Alzheimer pathology leads to a sort of a variety of cognitive issues, of which memory impairment is probably the most well known and probably the most prevalent. But be careful, there are a whole host of other cognitive domains that can be affected, and sometimes even with sparing of memory. That said, that's within the Alzheimer's spectrum, I would say. But you're right, there are other dementias, I would say, notably dementia with Lewy body, for instance, where also memory is spared and where disorientation and spatial disorientation is one of the key elements that happens first and sometimes only before memory is affected. We have, of course, frontotemporal dementia, probably the as prevalent as Alzheimer's disease in patients younger than 60 years of age, where memory is spared and totally not affected even later in the disease, where behavioral issues are the main issue and main driving people to come to a cognitive clinic or memory clinic. So behavioral issues or language issues or both. So there are different types of dementia, different forms of dementia that may actually present themselves with different and variable cognitive issues.
That's very helpful, Philip. And it sort of leads us, I think, nicely into maybe some consideration and your opinion on the importance of the location of the pathology. So I suppose, because of our historic legacy of research identifying the pathology in the earlier stages in hippocampal areas, medial temporal lobe areas, inevitably we've been drawn towards episodic memory as being the challenge that people often present with. But my layman's understanding of tau pathology, I am a mere psychologist, so important to put that caveat, is that tau pathology can be very much more variable than amyloid pathology. So there are other key brain regions that seem to be prone to the accumulation of tau pathology even quite early in the disease, which sort of suggests that we should be a bit more open-minded about the consequences of that. If it were prefrontal lobe damage, it might well give people difficulties with working memory and their executive skills. What would be your take on the importance of recognizing that distributed pathology?
Well, I think you're quite right. I think what I alluded to earlier in my atypical Alzheimer's a little expose, I think that is mainly sort of interestingly here not driven by amyloid pathology. That's actually quite uniform in all the cases of Alzheimer's disease. Amyloid pathology occurs in the same places always, but tau pathology is very variable, and the location of tau pathology is much more, I would say, associated and correlated with whatever cognitive decline and the cognitive deficit one may measure. So indeed, it is the tau pathology and the location and the amount of tau pathology that actually gives rise to certain symptoms. That's why it's safe to say that in the Alzheimer's, I would say, talking back again about the Alzheimer's hypothesis and the cascade of amyloid giving rise to tau pathology, you can have amyloid in the brain for a long time without notable symptoms. Even with you doing your cognitive testing, you may actually pass that really brilliantly. But as soon as tau pathology occurs, driven by amyloid pathology, as soon as tau pathology occurs in the medial temporal lobe, you get episodic memory impairment. In the parietal lobe, you may have executive dysfunction. In the frontal/temporal lobe, you may have language issues, etc. As soon as tau pathology develops distant from where originally the amyloid pathology was, there you get the cognitive decline and certain specific symptoms associated with that amount of tau in that region.
Yeah, and I've always been intrigued by the fact that when we categorize people as having mild cognitive impairment, MCI, we tend to be much more specific about their presentation. So we have a taxonomy of different types of MCI. And then curiously, you cross over into confirmed Alzheimer's disease, and we start to see you as quite homogenous, which always seems to be a loss of possibly very important, interesting information. So
Yeah,
interesting that happens.
yeah,
Fantastic, Philip. I think you've done a really good job of laying the groundwork for the understanding of the pathology. And I wanted to move to some other topics, all of which I know you have a particular interest and vast amount of experience of. And one of them would be about this idea of wellness. So if we move on to talk about wellness, what is your advice in the context of various aspects of people remaining well? So issues around medical food use, food intake, and supplement use, all of which often come up in our consideration of this topic. What's the standard line for you at the Alzheimer's Centre when this question comes up from people living with Alzheimer's disease?
yeah. Well, it's a giant leap from the amyloid hypothesis to wellness, I must say. But knowing you, that's I could have expected it. Um, so yeah, wellness. I would. I don't particularly like the word wellness because I always associate it with sauna and other sort of things you may do in the weekend. But I think what is best known as lifestyle factors that have been, I would say, of interest over the last 10, 15 years, notably the last 5 years, I would say. Um, it's about the idea that certain lifestyle factors and lifestyle modification actually could perhaps have an influence on the course of dementia. So it started actually with the several papers of the Lancet Commission. I'm not sure whether the first one was actually 2010 or something, sort of pointing to the fact that environmental factors, lifestyle factors like obesity, like hypertension, like education as well, are also important in sort of causing dementia. And by sort of modifying these lifestyle factors, we could perhaps decrease the incidence and then also prevalence of dementia. Not Alzheimer's. I think dementia is very important to note that it is not about Alzheimer's, it's more about a general term dementia, which can be caused by several diseases. So I think that's actually spurred the interest in studying these lifestyle factors more intensely. We personally, and we were on the journey together, we studied the influence of medical food, which is basically sort of a nutritional supplement consisting of omega-3, omega-6, vitamins B, several vitamin Bs, and uridine in a special formulation that was actually in preclinical models had an excellent effect on stabilization of the membrane of the cell. So basically the communication between cells takes place in the synapse, and the synapses are formed by the membranes of the cells. So we did already in 2010, we put that to the test in a clinical trial and some clinical trials actually over time, and also in a European project in a larger context. We showed that actually using this specific supplement had actually a very interesting effect on cognitive function, not only memory, but also executive function, but also notably on hippocampal volume and even whole brain volume. So that also taught us at that time that there was an influence of these nutritional factors on things that we consider hard biomarkers like hippocampal volume. I think from that time on, people started to be interested in lifestyle factors, nutritional factors, much more. And of course, Mia Kivipelto with the finger study showed elegantly that having a nutritional, I would say, regime and exercise and some other factors associated, and it is a sort of package as opposed to doing nothing in people who are at risk for dementia, being 65 and older and have risk factors, actually made a difference ultimately in a couple of years' time, mainly in executive function and mainly in those people who are ApoE4 carriers. So that actually led to the ongoing debates, sort of how much of these lifestyle factors are actually, I would say, modifiable, and how important are they? So going back to the Lancet Commission report, there were several others actually reporting more and more risk factors actually associated with the prevalence of dementia. Even cholesterol was now implicated recently. So it again sort of stressed and amplified the notion that all these risk factors together and all these environmental factors, all these lifestyle factors together have an impact, may have an impact on dementia. Now, if you go to real clinical trial evidence, aside from what we did with Suvenate in 2010, with MIA in the finger study, some other interventional trials actually were quite disappointing. I think the best evidence is coming from some of the hypertension trials where people with hypertension were treated aggressively. Ultimately, that had a positive effect on cognition and perhaps even on incidence of dementia. But the real sort of, I would say, evidence needs to be found still, because for me, as a trialist, as a neurologist, I want things to be proven in clinical trials. And that's why we did the Suvenate as rigorous as we could do it. And the finger trial was also an attempt, but now we have to have the worldwide fingers, we have the pointer, we have several sort of ongoing studies worldwide to show that changing lifestyle factors and changing lifestyle in general is beneficial for patients, even when they already have a dementia diagnosis. Now, you asked me, what do I do in practice? And in practice, we took a very pragmatic approach in saying, well, it has been shown that whatever is good for your heart is also good for your brain. So, indeed, if you have this diagnosis of Alzheimer's disease or any form of dementia, what can you do? If you ask me, well, try to work on your lifestyle, try to exercise as much as possible, take care of your diet, sort of try to reduce the amount of carbohydrates, increase the amount of polyunsaturated fatty acids, eat the Mediterranean diet. That has been shown also to be beneficial. So eat as healthy as you can, don't smoke, exercise much, lose weight, and that sort of thing. But I always realized, sort of being in front of patients who had this devastating diagnosis just sort of given to them, that that was a very sort of mediocre type of advice, because yeah, what's good for your heart is good for your brain. Yeah, of course I do it. And some people actually took it the wrong way, because yes, I did already that, and actually I lost weight, perhaps because of the disease, and I exercise a lot. So what more can I do, doctor? And then I actually felt, yeah, even more stupid, because I had no answer. So I think it's really very important, but we should all do this. And the sort of the proof is still to be sort of given that intervening in all these lifestyle factors at the same time, meaningfully and percentage wise also dramatically, ultimately in years time would decrease the incidence of dementia, because every the evidence that has been gathered is all retrospective, and a few of the prospective clinical trials have very small effects, and actually small in number as well. So we really need evidence. So I applaud Mia for doing the worldwide fingers and the pointer study, and it's really a very, very big achievement. But what if the result is neutral?
Mm.
Do we then stop this? Do we then say, no, you don't have to exercise, you can just start smoking, drink alcohol? No, of course not, because it's so in a way you can also say, why would you do these trials? Because we have to take care of our lifestyle anyway, because of several other reasons. So I'm struggling with this concept,
Mm.
as you can imagine, because I took a long time answering your question. So it means I'm struggling with it. Yeah.
I thank you, Philip, and it's a helpful background. But what I'm hearing is that a one size fits all for people coming to clinic is unlikely to be a universal fit. And you mentioned ApoE4 status, which
Yeah.
has come up a lot in the last couple of years at conference. So, is there a strong sense in which you think people's genetic status interacts with lifestyle choices? Are there different forms of advice you'd give people depending on their ApoE4 status?
Yeah, yes, I would say yes. So ApoE4 is a well-known risk factor. I think the first publication came in 1993. It's actually a cardiovascular risk factor that was known already for a long time in the cardiovascular field. It increases your risk for cardiovascular disease. But lo and behold, it also increased the risk for Alzheimer's disease. Notably, if you have one E4 allele, it's roughly 8 times the risk, and two, you have 16 times the risk for Alzheimer's disease. Doesn't mean that you will get it. It's not a causal gene, it's a risk gene. So you may escape the disease also, but you have a higher risk. And people who have a higher risk want to do even more to reduce that risk. And the finger study, but also studies from France with the omega-3 diet interventions, they showed that people who have this ApoE4 risk have actually also a larger benefit of these lifestyle interventions. So they actually should do it. And that's also the advice that we give to patients. So if you have the risk factors, there's an extra motivation to do even better in your lifestyle. I would say reduction, whatever you can reduce in your lifestyle. So yes, that's true. Other than that, I would say still the effects are very, very small, if at all. So, but people need to do it because it's also gives you a sense of I'm doing something against the disease myself. But I would be much more sort of in favor of having gene therapies actually directing that risk gene specifically and trying to reduce the risk by removing one of these E4 alleles, turning them into an E3 or an E2, and that would immediately reduce the risk for Alzheimer's disease with 8 or 16 times less of a risk. But then, of course, to prove that, you need very long trials. But there is also a lot of development there. Companies are working on that. And luckily, we have the biomarkers to measure the effect probably in a shorter time frame.
Mm-hmm. Philip, that's very, very helpful. And the gene therapy, I think I would imagine that's something we'll probably hear a good deal more about in the next few years. So thank you for mentioning that.
Yes.
And it's worth mentioning to listeners and viewers that Mia's appearing on a later episode of this podcast. So we'll also get to ask her about the finger studies that you mentioned. Philip, about 10 years ago, you very kindly sat down to lunch with me and said, had I thought about an academic position? And I had a conversation with you, and you very kindly suggested I should apply to the Amsterdam Alzheimer's Centre, which I was delighted to get that encouragement from you. But it causes a curiosity for me. So whenever I'm presenting in the UK and people see the affiliation, the question I almost always get is, why have I maintained an affiliation for a decade with the Amsterdam Alzheimer's Centre? And my standard reply is because I think it's a really good model for disease detection and effective management. And I think one that sets the standard. You've experience of different care systems for people living with Alzheimer's disease. What do you think makes the Alzheimer's Centre in Amsterdam different from elsewhere?
That's very kind of you to refer to that specifically, John. Did you also tell people that we rejected your application 3 times before accepting it? No, I'm joking. No, of course, no. We were happy to have you. Yeah, it's not something that I would boast about, but the Alzheimer's Center is unique in the sense that from the very, very beginning, actually, we had the idea to have care and research to go hand in hand. So the basis of the Alzheimer's Center is that it's a research center and also a care center for people who want to have a diagnosis and want to know what's wrong with them. So from the very beginning, we organized the centers to such a degree that we could give an answer to the question that the patients and their physicians had. Well, is there a form of dementia? Do I have early Alzheimer's? Do I have another form of dementia? Or is there nothing wrong with me? To answer that in a very diligent way in a one-day stop clinic, where we integrated all sort of the diagnostic workup that was needed in one day, but by the same time doing that in such a way that we sort of acquired data on all these people and stored them, and that became the Amsterdam Dementia Cohort. So it's a very lovely combination of care and research. Also in the people that work there, they care for patients, they see patients, they do diagnostic workup, but also at the same time they are researchers. So it's a very sort of intertwined sort of thing, and it also sort of made us sort of able to use the earliest, I would say, developments in CSF biomarkers and later on blood-based biomarkers and PET biomarkers. We implemented that very early on in our clinical workup already, because we said, well, we have this CSF test now. It's actually research, but we'll do it on you anyway, and we follow you over time and see how this test actually plays out. So we had a test phase for 1 or 2 years, and when we thought it would actually, it really sort of worked very well. There was a high sensitivity and specificity and high accuracy, and the test performed really well. Then we implemented immediately in our clinical routine, and then we went on to do tau PET and amyloid PET, and later on the blood-based biomarkers. And that was possible because there was the infrastructure, and we could do it, and we had a sort of the same patient number every week, 12 weeks, 12 patients per week and 50 weeks per year. So 600 patients every year. So this the database grew with 600 patients every year, and we had everything on those patients. So neuropsychology, of course, MRI, and all the other biomarkers, which made it a really, really rich data set. But at the same time, people were very happy because before that time, before I started this in 2001, people had to wait 6 to 8 or 12 weeks actually to have an MRI scan, a neuropsychological evaluation, the blood test done, and even perhaps even something else. That took 12 weeks, 3 months, 4 months that you were in agony and say, well, what's happening with me? And is there something wrong? We could answer that in 1 day. So that was really very sort of helpful for patients, and they came from all over the Netherlands to do this to the day, actually. And we still haven't changed this setup because it works so really well for research and for care.
Thank you, Philip. And I think that's certainly the experience of talking to colleagues. There's that shared sense that we're there to do research, but also deliver care. And that comes across for me really strongly. Yeah. Thank you. I'm going to go to a slightly more open-ended topic. So I'm going to get you to look in your crystal ball for this next question. You've played a key role in improving our understanding of brain function. What area of research do you think will provide the next big breakthrough in Alzheimer's disease?
So there are several answers to this one, but I think if I look back, I think the biggest change in our thinking and our approach to dementia and disorders that cause dementia is the fact that we have biomarkers. The fact that we have biomarkers for the underlying pathology has helped the field enormously, and most notably has helped drug development. So the fact that we have now 2 monoclonal antibodies against Alzheimer's disease, whatever you may think of it, whether you think the effect is large or the effect is small, it does what it should do. It does actually affect the pathology of the disease. And this development was only possible by the fact that we had biomarkers to measure that effect and to identify the right patients for the right trial at the right moment. So my vision for the future is that we will continue this journey by developing biomarkers for all the other pathologies that are also present, because we didn't talk about TDP-43 pathology, we didn't talk about alpha-synuclein pathology, we didn't talk about other dementias which have tau, but a different form of tau that we cannot diagnose properly now because we lack the proper biomarkers. So for me, going forward, it's really extremely important that we develop biomarkers for all the different pathologies and develop drugs to target these different pathologies.
That's very helpful. And just to revisit your earlier comment about jumping around in topics, your time with us is precious and limited. So I've tried to get to all the key issues that I know from conversations with you in the past that you've had a key opinion on. And there's one more which is very contemporary, particularly for people living in the UK. So the UK Parliament has just approved a new law for assisted dying to go forward. It's still hugely controversial in the UK as a topic, and I think it's at least provoked a discussion. And I think it's probably not well known that assisted dying in the Netherlands has been available since as early as 2002. I wonder if
Mhm.
you could share with us your experience and thoughts of this topic, please.
Yeah, so you're absolutely right. So we had a law on euthanasia, I think early 2000 already, with a very sort of one of our best healthcare ministers we ever had. She unfortunately died a few years ago. She really sort of fought for this, and this made it possible that people uh, having a disease that was fatal, and there was no no future for them anymore, and there was basically no treatment, they could opt for euthanasia actively. So it's not just stopping the ventilation machine or stopping any sort of other medication. No, it's actively sort of making sure that somebody dies peacefully at the moment that he or she wants to do this. So we have this. This is legal in the Netherlands. The doctor has to apply for certain authorization. Two independent other doctors has to verify that there is indeed a disease that is not curable and that will will really sort of terminate this particular individual's life at a certain moment. And then you can go ahead, and you're not sort of how do you say this? You're not breaking the law. It's always sort of judged very, very sort of carefully. Now, in recent years, we have seen this law being opening up to people with dementia, not not only in the earlier stage, which I have experienced myself in my clinic a lot of times, that people said, "Yeah, okay, so I'm 55 years of age. I have Alzheimer's disease. I've seen the disease with my aunt or my brother or my mother. I don't want to end like that. I actually want to do something about it, and I'm going to ask my GP to help me." This would also qualify for euthanasia because it's a disease for which there is no cure. The end is very clear over there, and somebody may actually decide to stop it earlier at whatever moment. And that has been done quite often. Now, the latest development is that we also acknowledge the fact that people sometimes wait too long, although they wanted not to end like this. And they said, I don't want to go to a nursing home. I don't want to be in a stage where I don't recognize my children anymore, not even my spouse anymore. I want to be dead before that. They're sometimes too late. They also sometimes forget that they actually wished for. So they end up in a nursing home. And when then there is evidence that this was documented in sort of and seen by a GP, for instance, or by others, that this was documented and clearly not the wish of the patient to be in that situation, euthanasia is also possible, despite the fact that the patient, him or herself, cannot actually consent anymore because too far gone, too demented. So there has been some legislation on that as well. There's some very famous cases in the Netherlands that were judged to be uh, according to the law and allowed. And so this is now where we have gone, and this is where it is possible. And this is what you may call assisted sort of a suicide or assisted dying. There are several names for it. I call it rather active euthanasia because it's something actively that somebody has to do. Now, GPs and doctors in general sometimes have a hard time accepting this, and you are not obliged to do it. You are not saying, well, if the patient wants it, I need to do it. No, we have now special expert clinics in the Netherlands that may be called upon if the GP said, I cannot do this myself. I know the patient for too long. This is too dear to me. No, I don't want to do it. Then you can actually sort of go to an expert clinic, and they will do it according to the law. They will have independent people judging the case. And there have been some really interesting cases also, even on television shown, where this has been successfully done. Yeah.
Mhm.
So again, a long answer to your question, but that's how it is at the moment. Yeah.
It's a very welcome answer because I know that particularly in the UK where this is an issue currently with the legislation, there's a little bit of disinformation and it's such a sensitive topic that
Yes.
it's sometimes
Yes.
quite hard to have the sort of nuanced and subtle discussion you'd like.
Yeah.
So hearing your account, hugely helpful. And I hope that at least people listening in will feel better informed about what it looks like in practice. So this has been an excellent discussion on the relationship between beta amyloid peptide accumulation and the progression of Alzheimer's disease. You've very helpfully simplified a complex topic and given us all cause to be optimistic about improved detection, prevention and treatment of Alzheimer's disease. So thank you.
Likewise, John, you know that, and it was a pleasure doing this for you and with you.
Thank you also to our listeners for joining us. In our next episode, we'll continue this journey by shifting our focus to prevention. I'll be speaking to Dr. Mia Kivipelto, a global leader in dementia research, about the role of genetics, lifestyle, and environmental factors in Alzheimer's disease risk, and what we can do to delay or maybe even prevent its onset. Until then, thank you for listening to The Progress Profile, Alzheimer's Research in Focus.